Good morning, everyone. Welcome to Learn Anatomy Online again on Monday, 13th of December. Very close to Christmas now. Yeah. Well, if you pop a message in the box, if you're around, if you're with us, looks like we've got a few people in with us this morning. Cool. So we did. Bony landmarks, morning Julie. Bony landmarks and bones and joints of the knee. Just pop you over here. Good morning, Julie. Last week, and now we're going to start to layer on the ligaments as well. So going to start having a look at the joint capsule and meniscus, so all the passive structures around the knee. Morning, Al. Good to see you, mate. We've got a few of the regulars in this morning. So. Yeah, and also if you haven't seen it already, I'm sure you probably have. Just grab my arrow. We are going to see these fellas in March and April next year. So we're the London dates filling up pretty quick. I think we've probably got about 8 spaces left, I think, on London. A few more spaces left in Keele, in Staffordshire. So if you're in the north, kind of Manchester, Liverpool, even like Newcastle area, so in that kind of northeast, northwest area, or even in the Midlands around Nottingham area, then Keele is probably the best place for you guys to go. North Wales is easy to get to as well, and obviously in the south, then the London venue is a lot easier. So if you go to clinicalanatomy.education, all the details to join me live with some cadavers and have a look at the anatomy in real life, then you can come and join me on that. Cool. Right, let's get going. Just get rid of that one. Here we go. Okay, cool. So we're going to have a look at the passive structures of the knee. Any guys got any questions, then just give me a shout as we go along. So we looked at the hey Stevie. Bonjour, ça va? We looked at the bony structures of the knee. We looked at the tibial plateau and the femoral condyles on the top. Now we're going to have a look at the stuff that kind of binds all that together. And these are really important to understand because because of movement, but B, because of injury and how certain things get injured because of the shape of them and because of the position of them. So really, really useful if you do clinical testing to know these things. Morning, Natalie. Good to see you again. Been a few in a row now. That's good. We're going to first of all have a look at the collateral ligaments, and sometimes these are called medial and lateral collateral, and that's what I tend to call them. But sometimes as well they're called tibial and fibular collateral ligaments because of where they attach. And I guess it's better if it's more tibial and fibular because you know exactly where they are in the body. We do have collateral ligaments in the fingers, we have them in the toes, we have them in the elbow. So if you use tibial collateral ligament, then you'll know exactly which one it is because there's only one tibia. So, but just to let you know, they are used interchangeably. And we usually say medial for the tibial, And for the lateral, for the fibular ligament, we call it a lateral collateral ligament. So LCL, lateral collateral, and MCL, medial collateral. So yeah, just to avoid any confusion, if you think, oh my God, do I need to learn more ligaments? No, they're all exactly the same. Morning, Tristan. Good to see you, mate. I hope you're not suffering from the dust too much. Your house is looking good. Cool. So, yeah, we've got a ligament on the inside of the knee. So if you have a look on here, so that this is why we do the bony landmarks first, because you will have already heard of some of the areas that we're going to talk about now. So, the medial collateral ligament is really broad and really flat, and we'll see it in a second. Very, very different to the lateral collateral, which is much more like a cord. And this is that there's a couple of bands of the medial collateral ligament, but if you have a look on the side here, so that's your medial epicondyle of the femur, and then it comes down into the Pezanserine area, Pezanserine, however you want to pronounce it, which is that area on the medial part of the tibia. So we looked at that last week. It's just medial to the tibial tuberosity. So yeah, medial epicondyle of the femur to the medial tibial condyle. So around that area, but it actually it extends quite low. Just see if I can find. I've lost my foot. Bear with me a sec. There it is. So it extends quite low down, sort of around this area on the tibia. So it's a lot lower than you think. It doesn't just stop up around here on that tibial condyle. It blends into the periosteum quite low down. So morning. I I have no idea what what you're trying to say there, Penny. But good morning. Okay, so yeah, we've got so that all blends down into this area here. So sometimes if you get medial tibial symptoms and it's a little bit angry around that area, then it could be a contribution from that medial collateral ligament, depending on the mechanism of whatever they've done. So if we have a look at the direction of this, it slants anteriorly and is longer than the LCL, so it does extend quite a long way. We'll have a look at the LCL in a second. You'll see it's no sound. Okay, I've no idea. I think it might be you. Yeah, I think everyone else is okay. Let us know if you can't hear, guys, or if everybody else's sound is okay. Yeah, so protected by the Pezanserine tendons. So these tendons we're going to have a look at in the next section. So we've got 3 tendons that attach down into that medial area. We've got the Sargent group, SGT, so sartorius, gracilis, and semitendinosus, all attach into there. So the medial collateral is underneath, or kind of blends into those tendons. Morning, Becky. Morning. And yeah, looks as if Natalie's okay. Hopefully everyone else can hear us as well. Hey, good. Brilliant. Good, Penny. Yeah, attaches to medial epicondyle. And this is the key thing with the medial collateral ligament. It also attaches onto the medial meniscus, and we'll have a look at that in a second. And it's quite a tough fibrous tissue, and it literally sticks to the medial meniscus. So if you have an injury to the medial collateral ligament, you usually injure the medial meniscus as well, or the other way around. So yeah, just something to be mindful of. They basically attach to each other. So the medial tibial condyle and upper medial shaft of the tibia. So that's where it goes down to here. So probably around about there. So that kind of proximal third of the tibia. There are superficial and deep portions, and they both have different roles. The superficial anterior fibers are more the tibio-collateral ligament, and then the deep posterior fibers more posterior oblique ligament. So but they both work together. So when you see it on the cadaver in a second, it's very hard to distinguish between the 2 fiber directions. They all kind of meld into one. So yeah, and if somebody injured it, you would never be able to do a test to go, oh yeah, that's the posterior oblique fibers that are causing the problem. We just wouldn't know. Okay, so yeah, it's interesting to know, but we wouldn't know how to test that. What this ligament does is it restrains something called valgus. So here's your tib. Let me just switch me onto the bigger screen again. Get rid of him. Okay, cool. So imagine your femur on the top. So this is the medial side, this is the lateral side. So we've got the femur on the top, and your medial collateral ligament will be around here. So because it attaches above and below here, what it will prevent is those kind of movements to the side. So when the inside of the knee starts to open up, and that will happen in a kind of knock-kneed position. So if the knees start to come in, then that will start to stress that medial collateral ligament. Now, that movement has been demonized for years, and actually it's an entirely normal movement for you to do. So if you jump and land, you tend to go into a bit of a valgus position, so the knees come in, and that stretches the tissue. You'll get some sensors activated within the medial collateral ligament, which will then activate the muscles to then pull you out of that position. And if you play a sport where you have to change direction, you have to go into a valgus knee position. So it is not a bad thing to do. The problems usually occur when you're not prepared for it, or if you have excessive force into that position. So if I landed and then went into a valgus position, and then someone clattered into me from the side, and then over valgus the knee, and all of that load then going through the middle part of the knee, that would probably cause you an injury. But if you have a good training and your practice sessions involve going into that position, coming out of it, and changing direction, then you will be absolutely fine in a game. So we've got, I think sometimes, especially in the fitness world, we've got to be really careful because there's some jump tests that you can do. There's one called the LESS test, the landing error scoring system. And even the name of it is a bit of a problem because we're looking at landing errors, and knee valgus, so going into a knee valgus position, is considered to be an error, and actually it's just a normal position. And some people go into more knee valgus than others. It just depends on whether they can cope with it or whether they can't. So the way that we build up the capacity is by training it, and you do it in a safe environment in the gym. And then when they go out and play, they should be fine. Okay, so we've got to be careful with demonizing these movements because they're not all bad. So that's what this inside ligament will do. So broad, couple of different fiber directions, and it will help with reducing that knee valgus position. It also resists lateral rotation, so rotating the tibia laterally. Hyperextension of the knee, and we'll have a look at these in a sec, and tibial translation, so when the tibia moves front and back, okay, and it shouldn't move front and back. So but it will do naturally with movements, but it shouldn't do it excessively. So the ligaments will help to reduce that movement back and forth, and we'll have a look at some videos on that in a sec. So I'm just going to show you the PCL, and then we'll have a look at some videos of these. So this is the the LCL. This is the lateral collateral ligament. So we had a look at the medial one before, so on the inside of the tibia and femur. Now we're going to have a look at the LCL, which is the lateral collateral. This is sometimes called the fibular collateral ligament as well. So again, if you've heard both terms and you're thinking, oh my God, there's another ligament that I've never heard of, it's exactly the same ligament, it's just given a different name. So the lateral collateral is shorter than the MCL, and if you have a look, it's not broad at all. It's like it's cord-like, it's like a pencil, and it's for want of a better word, it's quite twangy. Okay, so and you should be able to or you may be able to palpate this one on the lateral aspect of your knee. It's a lot easier to palpate than the medial, because the medial collateral is quite flat and it kind of hugs the joint surfaces, whereas the lateral collateral, there's a gap between the lateral collateral and the actual knee joint, and you'll see that in a second. So sometimes you can palpate these. So it's pencil-like, it slants mostly posteriorly from lateral epicondyle. So we had a look at that before. the lateral epicondyle of the femur, and then it goes down onto the fibular head, which we had a look at last week as well. So again, this is why we do the bony landmarks first, so that as we start layering on the other tissues, you can see where things attach to. It's separated from the lateral meniscus by the popliteus muscle, and we haven't had a look at that yet, but we will do. So there is no attachment here to the structures that are underneath. It's completely separate, and there is a gap in between. So if you injure the lateral meniscus, you can injure that on its own, okay? There may be no effect on that lateral collateral ligament at all, but because the medial is connected to the meniscus, you often get them injured together, okay? So that's just something to be aware of. Surrounded by the tendon of the biceps femoris, so one of your hamstring muscles will come down here. We'll have a look at that when we get to the muscles, and it tightens in full extension. So as you extend the knee and your leg is straight, your collateral ligaments will be on the most taut. So there should be absolutely no movements in your knee when your leg is extended. So if we think about the clinical tests that we can do to help assess the integrity of the knee, if you have a slight bend in your knee, well, it depends on how big the bend is, but let's say your knee's at 90 degrees and you're trying to test the collateral ligaments, they're going to be lax anyway. So if you test them in that position, they will feel like there's a lot of give. And that's because there is. They only become taut in extension. So sometimes we test it just off extension, but if the knee can move into a valgus position, so the knee coming inward, so a knock knee position, when your leg is extended, that you have a problem with that medial collateral ligament, because it should be tight as a drum. Okay, so nothing should move at all. Now, the movement that the LCL prevents is the opposite movement. So the medial side comes inwards, and that opens up the inside of the knee. If the knee goes outwards, that opens up the outside of the knee. And the way to remember this, if you're standing there with your legs, with your knees apart, then you've got air in the middle of your legs. And if you bring your legs together, so you're knock-kneed, then you haven't. Okay, so when you're knock-kneed, your legs look like an L, so that's valgus. And then when you are bow-legged, so imagine you're riding a horse and you've got your legs either side, that is a varus position, and you have air in between your knees. So varus, legs out, bow-legged, valgus, knees in, and knees knocking, basically. Okay, so that's how to remember those. So that restraining of varus and the restraining of valgus should keep our knee moving in the way that it's supposed to. Basically, you will get some rotation. We'll talk about that as we go through. Yeah, you shouldn't get any side-to-side movements of the knee because of these ligaments. Okay, so let's have a look at those. Not that one. Just pause that one. Here we go. So collateral ligaments are just here. So there's your fibular head, just there. That's your lateral meniscus, and then that's your fibular collateral ligament, which is your LCL, lateral collateral ligament. Okay, so there it is there, and you can see that it looks very thin like a cord, exactly as it was described before, and it attaches from your lateral epicondyle all the way down to your fibula. Okay, so and you can see the gap. So it doesn't attach onto the meniscus at all in that position there. And then as we come round, there's your tibial collateral. So that's the medial condyle of the tibia, just there. There's your medial epicondyle of the femur. And then this is the tibial collateral ligament, or the MCL, medial collateral ligament. And that goes all the way down here. Obviously, there's been some tissue removed from here, and there is a capsule that surrounds this whole knee joint, but we'll have a look at that in a sec. But the tibial collateral ligament attaches into the capsule as well. Okay, and we'll have a look at that when we get to it. So you can see it's really broad and flat and attaches into that medial meniscus. And there's your medial epicondyle, anterior medial tibia, and that's where the medial collateral ligament will attach, very broad. There's your medial meniscus. The MCL blends with the capsule of the knee and also connects to the medial meniscus just there. So that there is a direct connection to that medial meniscus. And on this side, no connection at all. Okay, so fibula head just there, cord-like structure. So there's your lateral epicondyle down to the fibula head, and that's where your LCL will attach. So it's not connected to the meniscus, just here. And there you go. You can see that you can literally slide things through there. There's no connection at all. So extension. So when the leg is extended, so when you straighten the leg, that will tighten the collateral ligaments. Okay, so both will be tightened in that position. And then when you flex the knee, so see they're taut there. As you flex them, they become lax. Okay, so when you're in extension, you can't rotate the tibia. Okay, it just won't go. So what will happen is you'll get rotation from the hip if you try to rotate when your leg is extended. You can only rotate the tibia when you have a bend in the knee, because then the ligaments are lax and then you'll be able to move it side to side. So that's important with rehab. Okay, so when you're looking at that terminal extension and being able to get into that position, it's important to know how you get into that position and what things may restrict it. Okay, cool. So those are the collateral ligaments. Just pop that there. There we go. And then we move on to something that you've probably heard before, called the cruciate ligaments. And the cruciate ligaments form a cross in the middle of the knee. And basically, cruciate means crucifix. Been watching Harry Potter recently, so it's the cruciatus. So we've got crucifix ligaments or cruciate ligaments. So they cross each other in the middle of the knee. So I've got a couple of ways to remember which one's which. So here you go. So if you remember lamp and then opposite, hopefully this will make sense. So the if on the lateral part of the femur, so that's where the L comes from with lamp, you have it, that's where the ACL starts. So it starts on the lateral aspect of the femur, and then it goes on to the opposite part of the tibia. So it goes on to the medial part of the tibia. Okay, so lateral, that's the L, is the ACL, and then the medial part of the femur is where the PCL starts, and then it attaches on the opposite, so the lateral part of the tibia. Makes sense? Okay, so what we'll have a look at that, and hopefully it will all become clear. Okay, so this is obviously a still of the cruciate ligaments. So we've got the anterior cruciate ligament here, and you can see, so it starts on the lateral femoral condyle, and then it comes forward onto the medial part of the tibia. Okay, so starts laterally, ACL, and then opposite on the tibia. So it's anterior medial intercondylar area of the tibia. So that's down here. That's where it attaches, and then projects posteriorly, laterally, and superiorly. So it goes backwards, to the side, and up. That's what those mean. Okay, so posteriorly is backwards, laterally to the outside, and then superiorly upwards. So that's the trajectory of that ACL. Okay. And the insertion is on the lateral femoral condyle. So it's kind of tucked on the inside of that femoral condyle, and we'll have a look at that in a second. So the kind of thing it prevents is anterior translation of the tibia. Now, what does that mean? So as you walk and run, as you're running along at speed, and you're making a heel contact, and then you're coming forward, and then the tibia is going forward like this. As you go forward in that position there, the passive structures of the knee will help to prevent slipping of the tibia forwards and backwards. Now, the anterior cruciate ligament, because of where it attaches on the front here, will stop the tibia sliding forward. Okay, so that's its role. So as you're moving along and you're running along, one of the roles of the ACL is to prevent that forward slippage, that anterior translation of the tibia. Right, and that's the passive structures. There are active structures, so the hamstrings that and the gastroc that do the same job. So they stop that anterior translation. If you have excessive anterior translation, or you have it with a twist as you fall and then get landed on, that's how you start to injure your ACL. Okay, so we can have a look at the. It makes sense how it gets injured because of what it does. So it also prevents excessive rotation of the tibia. So if you rotate too much, you're going to stress that ligament. If you anteriorly translate too much, you're going to stress that ligament, and hyperextension will also stress that ligament as well. Okay, there are bundles of ACL, and they are taught at full flexion, so they're tight at full flexion and full extension. Okay, so when you have a knee bent, again in that mid-range position, that's when the ligaments are a little bit lax. So there's a bit of give. It doesn't mean there's anything wrong with them. That's what's supposed to happen. But when you're fully extended and fully flexed, those ligaments are tight. They're solid. But when you have a slight bend in the knee, that's when there is normal laxity. So if you think about the kind of positions you might get into where you injure that ACL, it's usually bent knee, valgus, rotation, and it's where the LCL, lateral collateral, MCL, medial collateral, ACL, anterior cruciate are all lax, naturally lax. They have to be to allow us to move. But if you land in that position and then someone hits you, then you're more susceptible to injure those ligaments, and that's the reason why, is because of the movements that they prevent. And then the posterior collateral is basically on the back of the tibia, so it goes in the opposite direction because it's a cruciate, because they cross. Okay, so we've got posterior intercondylar area of the tibia, so that's this area around here. So there's your fibula head. This is the back of the tibia, just there, and these are the meniscus, which we'll have a look at in a second. So that's the attachment of your PCL, and then the PCL passes superiorly, so upwards, anteriorly, forwards, and on the medial side of the ACL. Okay, so it passes across. And this is the interesting thing with ACL ruptures is, and this is becoming more and more common now, they're being left rather than by it being operated on, because after about 9-10 months of rehab, the ACL or the PCL, whichever one's injured, starts to stick to the other one to form that solidity again. Okay, so it's really, really interesting. So you can have a torn ACL, but then the ends of the ACL will seek out something to stick to, and it usually sticks to the PCL, and then it forms a solid bond to stabilize the knee again. Okay, so, and that usually happens within about 9 months or a year. There's been some interesting studies on that, and more and more surgeons now. It depends on what you do. So if you're a pro footballer, you'll probably have it reattached. But if you're not, and you don't have that kind of job where you'd need that recovery process, you can get away with really good rehab, and then the ACL or the PCL will stick to another bit inside the knee, and you don't need surgery. Okay, so it's an interesting things that are coming out now. So the insertion of the PCL is the lateral surface of the medial condyle of the femur. So remember that lamp. So lateral ACL, medial PCL. Okay, so that's where it inserts there. And this prevents posterior displacement of the tibia. So if the ACL prevented your tibia sliding forwards, the PCL stops it sliding backwards. And that's less likely to happen. You usually get PCL injuries when you get clattered from the front and someone takes out your shins. So like you're being tackled in rugby, American football is another classic one where they go in low they hit the front of the shin and they send your shin bone backwards, but your femur's staying still, and that's a posterior shear of the tibia, which is basically overstressing that PCL, and you may injure it that way. Okay, so that's quite that's the common way to injure it. And again, if you have a look here, sorry, missed off the last bit there, but it's taught in full flexion and full extension. So again, MCL, LCL, ACL, PCL are all lax in a mid-range position. So if you land in that mid-range position, then your knee has less passive stability. So if then the forces of whatever task you're doing means you go into a position where those ligaments become vulnerable, you're more likely to injure them because there's more movement available. Okay, so if you're knee extended, knee flexed, then the ligaments are solid. Okay, so and those are the areas where you can test those ligaments as well, because there shouldn't be any movement of those ligaments in full flexion, full extension. So if you think about some of the testing that we do, so for the you can do, well, the draw test isn't a very good test, but you can do a test called Lachman's test. If you've never heard this before or seen it before, it is where you have someone on a couch, you put a bolster underneath their knee, so there is slight flexion in the knee, and then you hold underneath the back of the tibia and you pull the tibia forward to see if there's an anterior translation of the tibia. And if the ACL is intact, there shouldn't be any movement. Okay, so that now hopefully you can visualize why we do that test and why the leg is in that position. The anterior jaw test, the knee's bent quite a lot. And then you can pull forward, and there will usually be some laxity in those ligaments, so it's not a great test. Oh, that's cool. Amazing. I have a client that has had successfully rehabilitated an ACL tear. He opted not to have surgery and deal with it conservatively. He was interesting to work with. Yeah, brilliant. You can have some really, really good outcomes with people who don't have surgery. It's the same with the Achilles as well. So it depends on the gap in the Achilles. But I think if it's within a centimetre, they'll leave it alone in a boot, and then the Achilles will start to reattach itself. Okay? And obviously you need to be mindful that you don't want to do too much plyometric jumping in the early stages. But if everything's knitting together nicely, you don't need surgery. If it's a bigger gap, then you might do, and the outcomes are better if there's a bigger gap if you have surgery. But yeah, if there's a small enough gap, then it will knit back together. I did post about that on the movement therapy page a little while ago, and there was a paper about the ACL. So I'll see if I can dig it out and put it in the group. Cool. So those are your two ligaments, yeah, in the middle of the knee, ACL and PCL. Let's have a look at those. Ignore that video. See if I can find the right ones again. Cruciate ligaments. Here we go. Hopefully. There we go. Okay, I'll just rewind that. Okay, let's have a look at where we are. So lateral femoral condyle. So this is the outside of the knee. So we're looking at a right knee on this one. There's your LCL. So you can see that cord-like structure there. Fibular head just there. And then the medial femoral condyle and you can just about make out the MCL just there. Okay, so that's where we are, looking at the front part of the knee. So this is the inside of the joint we're looking at now. There's your ACL around the front. Just move that out of the way. And there's your PCL coming out around the back. Okay, fibular head around the back. There's your LCL again. So what they've done is they've taken away the lateral femoral condyle, so then we can see inside the knee a little bit easier. So that there is your lateral meniscus. Let's just have a look at that. So here you can see the direction of the fibre. So there's your anterior cruciate ligament. So you can see it starts on the anterior part of the tibia and then comes up and then in the opposite direction. Okay. And there it is there. So you can see how it crosses across. So lateral femur, ACL. So that's the LA part of LAMP. And there it is attaching there. Okay, so medial tibia up to lateral femur. And then the ACL's now been removed. So this is, sorry, no, it hasn't. That prevents anterior tibial translation. So if I just go back there. So this was the movement I was talking about before. So as the tibia slides forward, boom, that's what the ACL stops. Okay, so, and you can see by the movement there, there's no other structures attaching to that, and the movement anteriorly is minimal. So when you're doing a Lachman's test, that's the kind of, I mean, maybe a couple of mil you might be able to feel, but if it's excessively gliding, then we know that there may be, well, we're pretty sure that there's going to be a problem with that ACL. So there's the ACL removed, and there's your PCL left. Okay, so that's medial femur onto the lateral part of the tibia. Okay, and again, coming downwards and inferiorly. And then that stops posterior tibial translation. And then when they're both working together, along with the collateral ligaments, they help guide and glide that movement. And you can see how the meniscus move as well. Okay, I'll just play that again. So you can see meniscus moving. We've got laxity in the ligaments until you get to full flexion, and then extension, full tautness again. Okay. This is a good one. So if you leave all the ligaments alone, do they have the ability to reattach within reason? I know of the ACL and PCL. I've not heard anything about the MCL and LCL. So I've definitely heard case studies about the ACL and PCL, but the other two I'm not sure. I'd have to have a look. It's a good question. One to research for you, Penny. There you go. So the ACL, MCL, PCL, LCL help keep the knee stable as it moves. So it's passive stability. And within the ligaments, and we talked about this a few sessions ago, the ligaments are full of proprioceptors. So they tell your body where your knee is. Okay, so if they're being excessively lengthened, then the signals will be sent off to your spinal cord, and then it will contract the relevant muscles to protect that knee joint, because it and it will work in the opposite direction basically. So if you're going into hyperextension, then it will contract your hamstrings to stop that movement into hyperextension. Yeah, so whatever direction you go into, the active structures, the muscles, will help to try to prevent that movement. Okay, that's what's supposed to occur. Cool. Okay, let's have a look at the next bit. So we're on to the meniscus. What time are we at? Blimey, time flies when you're having fun. So meniscus. Meniscos means crescent. So meniscos is Greek, and that's why we get the word meniscus. That's where it comes from, and this is what they are like. So I'm just going to move me over there. So the meniscus are fibrocartilaginous crescent-shaped plates, and they sit on top of the tibial condyles just there. So this is a top-down view of your tibia. So looking from the top there. It's restrained by transverse and coronary ligaments. So there are ligaments that keep the meniscus attached to the tibia. There's a thick convex peripheral border which attaches to the joint capsule. Okay, so basically the outside of your meniscus is thick, and then the inside of the meniscus, it tapers down into a thin portion. Okay, the undersurface of the meniscus is flat, so that just sits on those femoral condyles, and it has very thin central margins. So all of this area here and this area here, these are all thin, and this area here, this is really thick. Okay, well, I say really thick, a few millimeters thick. Compression of the meniscus squeeze water into the joint space, allowing smoother gliding of the joint surfaces. Basically, the movement and the compression of those cartilaginous plates, if you like, they stimulate the production of synovial fluid. So as you put pressure through the knee, you lubricate the joint. So it's really important that we try and get that joint moving if it's not been moving for a while. So this is a really good image. So you can see the condyles of the femur, condyles of the tibia, and that's the meniscus. So it looks like a wedge. Okay, so it's wedge shaped, thicker on the outside, thinner in the middle. So the normal height of a meniscus is between 3 and 5 millimeters. And it's divided into an anterior horn, the body, and a posterior horn. So we'll have a look at those in a sec. The lateral meniscus covers 80% of the lateral tibial plateau. So that lateral tibial plateau, this bit here, is mostly covered by the medial meniscus. The lateral meniscus, and then the medial meniscus covers 60% of the medial tibial plateau. We'll have a look at the wedge shape of it in a second because that's important. The most of the meniscus is water, and then with the next biggest amount being collagen. Okay, so these are collagen structures, so they'll have a bit of give and they'll have a bit of play, which they need to have because we need that for movement. Now this is the interesting part. So only the periphery and the horns are vascular. So only the outer part of the meniscus has a blood supply. The inner part doesn't. Okay, so the outer part does and the inner part doesn't. The peripheral blood supply from the medial and lateral portions are from these arteries called the genicular arteries, and we'll have a look at those when we get to the blood vessels. The main source of nutrient is via diffusion from the synovial fluid, so we have to move to keep these meniscus lubricated. And the nerve supply is more extensive in the horns than in the body. So in the ends of the meniscus, there's more nerve sensation than there is in the middle bit in the body. Mechanoreceptors are found in the horns, and that's important for proprioceptive feedback, so knowing where your knee is in space, and then that feedback going back to the spinal cord to get your muscles to have your knee in the right position. And there are 3 nerve endings except the inner third of the meniscal body. So the actual inside of the meniscus doesn't have any nerve supply or blood supply. So you can have a meniscal tear on the inside and have no pain whatsoever because there's no sensation and there's no blood supply. What they may have, though, depending on what happens to them, is they may get locking of the joint. Okay, so if the usual way that the meniscus get injured, if you land and twist, and then it then kind of it rips the meniscus basically, and that is how we do the clinical tests. So the clinical test to test the meniscus is a twisting motion to see if we can catch it. Yeah, but that is also the mechanism of injury. So that's usually what you will see. So I'm not going to go through all these. This is just a bit of a summary. So if you want to, you can pause this. I'll just leave that up there for a second so you can pause it and then have a look at those. So there's a bit more information. And this is the one I wanted to get to. So if we have a look here, this is the way that the meniscus is arranged. Okay, so you have this big outer ring, so a thicker outer ring, and then it goes thin as it comes into the middle, so wedge shaped. But each of the sections is in a different direction. So it's very similar to a annulus fibrosis in the disc of the spinal discs, because if you had all of the fibers going in one direction, so say it was a circular direction, and then you twisted, it would just tear the fibers really easily. So we've got some fibers going lengthways, some fibers going widthways, some fibers going round, some fibers going obliquely, some fibers going in the other direction. So it increases the integrity of that meniscus, and you'll be able to stress the meniscus in different directions without it getting injured. Okay, obviously if it gets twisted excessively, then you can. So the radial fibers are woven between the circumferential fibers, providing structural integrity. Okay. Good question. So does the avascular part get nutrition from the movement or just the vascular part? I think it's just the vascular part. Yeah, that's a good question. I'd have to have a look to be honest, but I know the outside definitely does. I would assume that the inside does as well, but I don't know for sure. Okay, so that's a good one to check. Right, so let's have a look. Yeah, here we go. So this is the blood supply coming into the outside part of the meniscus. So if you have a tear in here, you may not feel it. Okay, and also it may not bleed. But if it's a little bit higher up, then you may do. Or what usually happens if you disrupt the inside of the meniscus here, and then that then loses the cushioning effect from the femur onto the tibia. So then you can get articular cartilage changes on that tibial plateau and on the femoral condyles, and that can generate inflammation. So you may get some swelling inside the joint if you've injured the inside of the meniscus, but it may not be the meniscus where you get the inflammation from. It might be the joint surfaces because they've been affected too. Cool. This is really important, and you'll see this in a second. We'll finish on this because we've been going on for quite a bit. So the menisci are not static structures; they move, and you'll be able to see this in a second, and especially the lateral one. Motion occurs with respect to the tibial plateau, and there is an anterior-posterior movement. Okay, so during knee flexion and extension, the lateral meniscus is displaced by up to 10 mil. Okay, so it can move quite a lot. The medial meniscus, not so much, about 5, and you'll see why in a second. Yeah, the posterior lateral fibers, so towards the back and the outside, limit the movement of the medial meniscus in rotation, and that is why we think the medial meniscus gets injured more than the lateral, because the medial meniscus doesn't move as much because it's stuck to the joint capsule. Okay, so as your knee twists, the lateral meniscus will move with it, but the medial meniscus can't move because it's stuck to the capsule. And that's one of the reasons why we think that it increases its chances of being injured. Right, let's have a look at the meniscus. Just get that on there. Here we go. So there's your femoral condyles without the meniscus on, and then these are the meniscus being put on the top. So you can already see they're a bit squidgy. And using my food analogies, they're a bit consistency of calamaris again, but like day old calamaris. So you wouldn't want to eat them. They're pretty tough, but they're a little bit squidgy as well. And the reason why we've got an O and a C, the O here, literally that is nearly a full circle. Okay, so these ends of the meniscus just here and here, they nearly form a full circle, whereas this one is more like a C shape. Okay, there's a big gap in between here and here. Okay, so they're different shapes, lateral to medial. So there's the picture that we just seen, and there it is there. Okay, so you can see the wedge-shaped structure. So that they attach, both of them attach on this interarticular notch. So these ones wider, okay, further apart, and these ones closer together, hence the O and then the C shapes on those. Yeah, they attach also to the joint capsule above and below. And this one, the medial collateral, is literally in it. Okay, so you can see it's basically stuck. So that's why we think it gets injured, because it can't move. Look at the movement of that one compared to that. Yeah, so if your knee excessively twists and you get smacked from the side or whatever, then you're much more likely to injure this medial meniscus than you are the lateral meniscus and the medial collateral ligament, to be fair. Yeah, okay, so you can see why the tests do what they do. So we want to try and rotate the femur on the tibia to try and catch the meniscus if there is a tear in there. But you can also see why it would get injured too. Cool. So Penny says, I had a chap in clinic who had a bucket handle tear. Yep, that is perfect timing. These are the meniscus injuries that you can get. Okay, so that's a bucket handle just there. Yeah, so literally it looks like, a bucket handle coming up. So as you're twisting, you'll get locking of the knee. And that's a common thing that you'll hear. So usually what will happen is they've jumped up, they've landed awkwardly, they've felt something in their knee, and then it feels okay for a bit, but then every now and then when they try and straighten it or try to run or change direction, it locks and they're like, oh, and then they can't move, and then they kind of shake it around a bit, and then it starts to free off again. That's indicative of a bucket handle tear. Okay, that's what you usually hear. So we've got radial tears going through the middle, parrot's beak tears where it's just come off a little bit, horizontal tears, so these are through the middle. Let me just get rid of that so you can see the other two. There we go. So you've got root tears right at the ends of the meniscus, and then I don't like that word, but normal injuries. Okay, so normal wear and tear. And this is the thing, when you look at the MRIs of people who have no symptoms, have never had a problem with their knee, they will usually have meniscal injuries, and but they've never known that there's been any problem, and we think it's because of that lack of blood supply, lack of nerve supply. You can have the injury there, not even know, and the only reason you'd know about it is if your knee starts locking up, so that you've had a bucket handle. There was a lad I saw last year who had a bucket handle tear, footballer. He's only 17, because he was quite young. Decided to have the op to repair the meniscus. If he was a bit older, if he was in his late 20s, early 30s, and he still wanted to play, you're probably better off just leaving him alone, because his recovery would be horrible. But with younger players, we usually the surgeons will opt to repair the meniscus. Okay, so it depends on their age as well. Cool. That was a long one today. I'm still not finished, and there's still some bits to do. So we'll catch up on the rest of it next week. Got only a couple of other bits to cover on those passive structures. And yeah, if anybody's got any questions about today, I will try and find an answer to your question as well, Tristan, about the nutrition of the meniscus from the movement, whether it's inside or outside. And yeah, cool. I'll pop it in the group. Tristan's had one as well. You've had a bucket handle tear and it split. Nice. Okay. Did you have it operated on? You can pop that in the group later on. Cool. Thanks a lot, guys. Good to see you all again on Monday morning, and I will see you next Monday, 10 o'clock. We will be doing it over Christmas as well. So yeah, on that Monday after Christmas, we never stop. I'll see you next week.